going. I'm not going to talk for the whole hour. I just want to give sort of a brief update on some of the work we've been doing around this issue and discuss some of the remaining issues that we're working on trying to resolve. I would be interested to hear your thoughts on how to resolve some of those issues. So this is a collaborative effort. We have a sort of big group of collaborators here, both at Yale, who've contributed to this, as well as at NIH and New York City Department of Health, and UMass Amherst and Roskilde. It's been a great experience working with this team. So we've been busy doing a number of different projects around COVID-19, and many of them have been focused on this idea of syndromic surveillance, which is the idea that the data that we're receiving from sort of official channels through, number of positive tests or percent of tests that are positive for coronavirus aren't very reliable due to testing issues. So we've been focusing on looking at other signals that might be less biased. So looking at things like the proportion of people who are going to the doctor with flu-like illness or coronavirus-like illness, so fever, cough, or other sort of spectrums of syndromes. And we've been sort of trying to develop some tools. A lot of health departments, most state health departments collect these data, and they have sort of real-time electronic reporting of those data. So we've been trying to develop some tools that can be deployed easily by practitioners in the field. So along with Marcus Russi, who's in Ted Cohen's group in the modeling unit, we developed an R package called XSILI, which basically allows analysts to go from sort of raw syndromic data that would be coming in, so like a line list of ER data. It sort of formats it into time series and then runs some basic analyses fitting seasonal baselines and estimating sort of increases above the baseline over time. So just as an example of this, the R package generates an interactive dashboard automatically when you run the analysis. And this is an example of, we ran the analysis on publicly available data from New York City Department of Health. And you can sort of use this to follow sort of usage of the emergency rooms in New York City for flu-like illness. This tool has been now used by a number of health departments. In Arizona Department of Health is using it. Partners in Health, which works internationally, is starting to use it as well. We've also been collaborating with Ted Cohen and Jeannie Pitzer and folks in their groups and trying to sort of evaluate the progression of the epidemic and trying to estimate epidemic growth in different settings. And I think they might be speaking in future weeks about those projects and working with colleagues internationally in Brazil who are interested in similar questions around pneumonia mortality. So, I mean, I guess everybody knows about COVID at this point. It's sort of everywhere all the time these days in terms of the news, but the first reported death in the US is now sort of backdated to early February. But testing was and still remains imperfect. That it was sort of slow to start in many places, and ISM was geographically uneven in terms of where the tests were being used. New York City saw really explosive growth of the epidemic, but other parts of the country have also seen sizable epidemics that are continuing to grow. There's likely a large burden of disease in many other places that isn't as readily recognized, which is where syndromic surveillance can come in handy. So sort of one form of syndromic surveillance is looking at cause of death statistics. That's sort of going to be the focus of the talk today. So the cause of death in the US is typically coded by a physician. In some states, nurses can also fill out the death certificate when it's due to a natural cause, or if there's an unintended death, so if somebody dies at home without without witness, then the medical examiner or coroner gets involved, and is responsible for determining the cause of death. So we use what's called a multiple cause of death coding in the US. So there's typically an underlying cause of death that's coded, and then there can be several contributing causes as well. So somebody could have coronavirus listed as the underlying cause of death, and then pneumonia or cardiac arrest could be listed as contributing causes. This process itself is, as you can imagine, kind of an art more than a science, and is heavily dependent on who's doing the coding and how they were trained, and their biases and so forth. And there's been a lot of criticism about this because New York State, for example, initially they used a definition like you could only put coronavirus on the death certificate if somebody had a coronavirus test, and then they changed it later to also include deaths where whoever was doing the coding suspected that coronavirus was the cause of death. So it became sort of a looser definition. And there was a lot of criticism of this, saying that you're going to start counting people who maybe were just dying of other causes or would have died anyway. So this becomes sort of a very controversial topic. But in any case, this is done sort of at sort of the local level by the doctor or coroner, and then reported up to from the states to the CDC and National Center for Health Statistics. So, as I said, sort of determining the cause of death is sort of an art, and many people who probably die of coronavirus will not have a cause of coronavirus listed on their death certificate. And we have a lot of experience with this from the influenza world. So if you look at other causes of death, so things like heart attacks, and even people who have diabetes listed as the main cause of death, if you sort of look at the data, it's you see these really strong seasonal patterns. You also see spikes that coincide sort of above the seasonal pattern that coincide with flu season and with flu outbreaks. So there's been a lot of work done retrospectively, going back to the 1918 pandemic and more recently to the 2009 pandemic, trying to estimate sort of how many deaths we miss if we just look at deaths that are sort of coded as having a cause of influenza. And for the 2009 pandemic, it was estimated that only about 1 in 7 deaths that were caused by flu actually had influenza listed as the cause of death. And so this issue of a squishy definition for how the coding gets done on the death certificate, as well as the issue that we're not really testing fully, leads to sort of numbers that we can't necessarily trust if we're just looking at the sort of reported numbers of deaths due to coronavirus. So the goals for this analysis were to sort of take the syndromic view. So instead of looking at coronavirus deaths, we wanted to look at sort of deaths that were due to pneumonia. And typically, because again, the death certificates and the coding is a little squishy, sometimes people who didn't actually have influenza, but just had pneumonia due to other causes, received influenza as a cause of death on the death certificate. This is a really well sort of established phenomenon. So typically pneumonia and influenza are lumped together in a single category. So we're going to look at sort of increases in rates of death due to pneumonia and influenza. We're also going to look at increases in deaths due to any cause, because that's sort of the least biased by coding practices. And we'll look at sort of how those compare to the reported deaths. And we'll talk about some issues with the reporting delays and how we're trying to address those. So the data we're using come from the CDC's public data sets. And so every week, the CDC releases the flu view, which is sort of a summary of influenza activity across the country. And one of the metrics they release is the percentage of all deaths that are due to pneumonia or influenza. So this image is from the latest week, or the report from the latest week, where you can see that there's sort of a clear seasonality to pneumonia and influenza deaths. You can see here there's this big increase above this sort of seasonal baseline, which was due to influenza in 2017, 2018, and then you can see the current year we're even above that baseline. We're also getting data on testing practices by state and data on confirmed deaths from COVIDtracking.com. So we're able to get these data for each state, so we know the number of people who had a death due to pneumonia or influenza, and then the number of people who died overall. At the national level, they also release a statistic that combines together. So if a person dies due to pneumonia or influenza or COVID, if they have any of those three or in combination on the death certificate, they get counted. That helps us to avoid double counting. So the basic approach that we're taking, and this is not adjusting for underreporting it, we'll come back and talk about the underreporting issue later, is basically a simple or straightforward generalized linear model. So the outcome is the number of pneumonia or influenza deaths in each week over time, so in different years. We're modeling it as a Poisson process where we're adjusting for seasonality using harmonics. So this is basically the first two terms of a Fourier series. We're adjusting for influenza activity. So basically the metric that we're looking at is sort of increases above a seasonal baseline, given sort of the current flu activity. And we're also allowing the effective flu to vary year to year. The reason for that is the flu data that we have are sort of aggregated across all years, and then not all flu seasons are equal in terms of how they affect different age groups and so forth. So we need to sort of allow that effect to vary year to year. And we also have a term that just adjusts for year-to-year variation in deaths. This is adjusting implicitly for changes in population size and also for delays in a very crude way in the most recent season. When we're looking at all-cause deaths, the model looks basically the same. The only difference is now we're modeling this as a negative binomial, and we don't have an offset term now. So in the previous model, we had pneumonia and influenza deaths, and the offset term was the total number of deaths in the same time period. And now we have we're just modeling the count of deaths in each week. So basically we fit this regression through the beginning of February, and then extend the seasonal baseline forward for the period from February to April. And the assumption here is that the seasonality and the level would have remained the same if coronavirus hadn't come in. We also generate prediction intervals from the regression model. We do this using a resampling approach that Nick Reich had developed for a previous study, where we basically take the regression parameters and sample from multivariate normal to capture the parameter uncertainty. And then we take these, the samples from the multivariate normal and sample from a Poisson, assuming that there's, that the samples from the multivariate normal are the mean from the Poisson. And this captures the prediction uncertainty. So it's sort of the combination of those two pieces gives us our prediction uncertainty. We're currently working on a Bayesian alternative that'll be a little bit cleaner and won't have to sort of go through all this resampling. So this is just sort of a top-line result of for each state on the seasonal baseline is shown in red here with the prediction intervals around it. And the black line is showing the observed proportion of deaths that are due to pneumonia or influenza in each week. And they're sorted here based on sort of the relative increase above the seasonal baseline in the recent week. So you can see New Jersey, New York, Louisiana, Colorado, Michigan, Massachusetts are all, and Georgia are sort of way above their sort of seasonal expected values based on the time of year that we're in. And there are some states where we don't see a lot of increase as of yet. So Mississippi's starting to climb up, South Dakota, not a lot going on. but some of these states there's sort of hints that they might be increasing from some of the syndromic data and the testing data, but not clear sort of signals as of yet. So this is data through April 4th. So these data are already sort of a couple of weeks out of date, but because of the reporting delays issues that we discussed earlier, it's difficult to get more recent data. So looking at this in a slightly different way, this is just showing us the rate ratio. So this is just the observed data divided by the baseline for 2019 to 2020 compared to previous years. So this sort of helps put this into context in terms of unexplained variation. And again, these are increases above a seasonal baseline, adjusting for influenza. So so these are sort of unexplained variations above the seasonal baseline. And again, you can see many of the states are well sort of outside sort of normal levels of variation. Some of the smaller states, it's a bit harder to pick out what's going on, but might be starting to increase. So what we did then was sort of lined up the excess deaths. So we took the observed numbers, the black line, and subtracted the baseline, the red line, and plotted that here. So the red line is showing us the time series of excess deaths over time. And then the blue line is showing us the reported number of COVID deaths in COVID tracking over the same period. It's important to note that these were the numbers that were reported at the time. So the numbers that were reported in March 15th for Georgia are what are shown here. Many of those numbers have been updated in official statistics, but these are sort of the numbers that were available at the time. So what this shows us, so if we look at Florida, you can see the red line is increasing, and then a couple of weeks later, you see the blue line increasing. And so what that's telling us is that there is an increase in deaths above the seasonal baseline that preceded the increase in coded coronavirus deaths. So what that's telling us is that there might have been sort of unrecognized deaths that were happening in Florida before they really started to ramp up testing. So the gray dashed line here is showing us the testing intensity in the state. So you can see the increase in the red line in Florida sort of precedes the increase in the gray dashed line. So telling us that testing hadn't really ramped up at that point, suggesting that there was some unrecognized increase that was happening there. You see the same thing in some other states. Mississippi, Texas also looks like, I'm not sure if I have Texas on here, but Texas also was showing a similar pattern. Other states, the increase and you see that in Maryland as well. Other states, the number of excess pneumonia deaths tracked pretty closely with the increase in reported deaths. So New Jersey and New York, those two numbers were actually tracking pretty closely together. And you can see that the testing was ramping up at roughly the same time the epidemic was taking off. So they were able to sort of capture the increase in the official statistics. So we also sort of looked at these increases in pneumonia and influenza deaths relative to increases in outpatient visits for influenza-like illness. So again, this is one of these syndromic definitions. So these are people going to their doctor who have fever or cough or other sort of symptoms or syndromes that would look like flu or look like coronavirus. And what we see is in many states, the increase in doctor's visits for influenza-like illness preceded the spike that we see in pneumonia and influenza deaths by about a week. So you can sort of estimate the change point for the red line and the blue line, and the difference between them is about a week on average. So this is interesting because the influenza-like illness data are typically available in a more timely way. So it gives you sort of an earlier signal. It might give you a preview what's to come in the death data, which tends to lag by a week or two. So there are some states where you can see, like Pennsylvania, the pneumonia and influenza deaths were sort of increasing a little bit after the increase in influenza-like illness. In Wisconsin, where they haven't really seen a strong increase in pneumonia and influenza deaths, down at the bottom here, you can see that influenza-like illness is starting to take off at this time point. So you might expect to see a spike in pneumonia and influenza deaths, by this time point. also looked at all-cause deaths. So what we see here is the increase in all-cause deaths during about a 5-year period. And so what we're comparing here is basically the red line to the gray line, and the shaded areas are the prediction intervals here. So you can see a clear spike. That the peak there is at April 4th. We estimate there are about 15,000 excess deaths. So that if you just subtract the gray line from the red line, you get about 15,000 excess deaths for the period from March 1st to April 4th. During the same time period, there were about 8 to 10,000 deaths that were sort of officially coded as COVID or recorded in COVID tracking as COVID. So, we're underestimating the sort of true number, or the full number of deaths by probably about 1.5 to 2-fold. But you see this like very sharp dip that's happening in the last week or so, it's really the last 2 weeks. And we think that is, we're pretty sure that that's due to reporting delays. So the question is sort of how reliable are those numbers for April 4th and before, and how do we deal with these numbers for the most recent weeks? Just as a aside, so the all-cause analysis was, we were contacted like a week and a half ago by the Washington Post, just sort of for advice on how you would conduct this type of analysis. And we sort of said, oh, well, we actually just did that analysis, and we were able to sort of feed them some of the sort of updated numbers from our model. And it was just published this morning in front page of the Washington Post, which was definitely an unusual experience, having sort of some of our work come out in the Post before we were able to get it out in an academic paper. We have a preprint up, but we're still sort of working on getting it sort of published through the usual channels. Okay, so the reporting issue is this. So what we've been doing is, so National Center for Health Statistics updates their website every day with sort of the number of their estimated numbers of deaths due to COVID and deaths due to any cause from the period from late January through the present. So for the last month, what we've been doing is every day or every 2 days, basically just downloading the data from National Center for Health Statistics and seeing how it evolves over time. So for example, if we look at March 28th here, so sort of where that dark blue line ends. So when we started measuring or downloading these data, it was April 3rd, and there was an estimated, a little less than 30,000 deaths for that week. And then you can see sort of each of these sort of rainbow lines is a measurement that was taken at subsequent dates. So you can see that the numbers for the week of March 28th sort of increased over time, and then eventually start to plateau, and the increases start to slow down a little bit. Likewise, for the week of April 4th, it looks like the numbers were down compared to the previous week when we first started measuring this, and then you see they increase, and then in the most recent week of data, you can see that they're sort of increasing substantially and continuing to climb to this point. So we've done some calculations just to sort of how sort of the rate of change of these stats over time, and they stabilize a little bit after 4 weeks. Even after up to sort of 8 to 10 weeks, there's still some changes happening in the data, but very unstable for the more recent weeks. So there are sort of two approaches we've been thinking about to deal with this issue. The first one is sort of a simple, almost back of the envelope type of approach, and the second one is sort of more of a regression-based approach. So in terms of the simple back of the envelope approach, basically what we did is what we're getting now are data that were reported in, somewhere around April 25th or so. So last Friday, these data were released. And we expect that they're going to be very incomplete for April, and somewhat incomplete for March, and maybe even for February as well. So the idea is to basically go back to the archives and look at the data that were released at the same time of year last year, so that were released around April 23rd or 24th, and look to see sort of how the provisional numbers looked for 2018 and 2019 compared to 2019 to 2020. So that's what this is showing us here, is sort of up through week 11, which is, week 9, which is towards the end of February. We can see that 2018 to 2019 and 2019 to 2020 are basically tracking very closely together. 2019 2020 is a little bit higher, probably due to population growth, but overall, the numbers were tracking very close together. So this suggests that the reporting delays from last year to this year haven't really changed much. So if we then do the same thing, but fast forward to the data that were collected in week 16, which was last Friday, and look at the data up through April 4th, this is what we see. So basically, you see that last year in their provisional death statistics, the number of deaths overall in the more recent weeks really went down pretty dramatically, whereas in the current year, the numbers went up very sharply. So a very crude estimate would be just to look at the difference between these two lines over the last 5 weeks or so, and you get something along the lines of 25,000 excess deaths. So that's actually higher than sort of the estimate that the Post put out today, which is about 15,000 excess deaths, and is maybe sort of adjusted for this reporting delay issue. The second approach is to take a model-based approach. And so now what we have is, we have the sort of provisional numbers from death reports from the last 2 months. So for each of those provisional death reports, we have a time series for sort of the reported number of deaths of the last 5 years or so. And what we can do is look to see how those provisional numbers are changing week to week. And we can use that to get an estimate for the state. I'll go through the details of the model in a second, but this is basically, so we apply this approach to data from all the states that we have, and sort of obtain an estimate for sort of the how complete the data were at different time points after the death. So this is basically showing us that each line here is a different state. It's saying that sort of 1 week after death, some states like New York State or New York City is the green line on top, where they're sort of hovering around 100%. So they have very little reporting delay. They have an electronic death reporting system, which sort of gets sent to CDC, and it's a very efficient system. Other states, are only reporting something like 20 to 20% of the deaths in the first week after the death occurs, and then as we go forward in time to week 2, 3, 4, and so forth, we get sort of more complete data, and it sort of starts to stabilize after a month or so. So what we're doing is basically taking the regression approach that we were using previously, but now adding, instead of having sort of one estimate for the number of cases at each time, now we have sort of a set of estimates. So we have the number of deaths for week 10 that were measured in week 11, and the number of deaths for week 10 that were measured in week 12 and in week 13, and so forth. So we have sort of a series of estimates. And then, so we include a dummy variable in the model, which accounts for sort of the delay in the estimate. So how many weeks after the death occurred are we? And then we also have a random effect for time. So this is similar to an approach that was developed by Nick at Harvard, where they have this approach called No BS, or knobs, which attempts to do something similar. This is fit in a Bayesian framework. Currently, we're just doing it in INLA, but we're going to move over to JAGS at some point to get a little bit more control over the fitting. Again, this is a similar plot to what I showed earlier, going out a little bit further in time. So this is basically the proportion of reported deaths in each week compared to what you see after week 8. So you can see that by the time you get to week 7, you're capturing pretty close to all the deaths. It starts to level out sort of around week 4 or 5 after the death, but varies a lot between states. This light dash blue is Kentucky, so you can see they're sort of a lot slower than some of the other states, and there's maybe a couple groupings there in terms of how quickly they report. So this is just plotting the AR1 effect, which gives us sort of a crude estimate of sort of increase above the seasonal baseline up until the current week. So we see New York going up here. New York City is actually off the charts here, as is New Jersey. But yeah, this approach maybe helps to deal with the lag. So you can see like Michigan down here. We can see sort of we still have an increasing trajectory. If we were to look at the raw data, you'd see a sharp drop in the most recent week. And for Massachusetts, it looks like maybe flattening there, which it's hard to say. Louisiana, it looks like it's maybe flattening or going down, but if you look at the raw data, it actually looks level. That suggests that maybe there was an increase that's not being picked up in the raw data yet. So anyway, this is still very much a work in progress, and we're sort of working on sort of formulating the models and getting them coded up. So, of course, with any type of sort of nowcasting approach like this, it's important to validate that it's working as expected. So, as more data accrue, we're going to be able to sort of, fit the model up through week 14, and then, see how it actually does in sort of capturing the backfilling process for weeks 15 and 16, for example. We're also interested in breaking this down further. So, currently we've been able to do analyses in pneumonia data and analyses of all-cause data, but there's a lot of sort of complicated patterns going on right now. So there's been, sort of reportedly increase or a decrease in car crashes because fewer people are driving on the road, so that makes good sense. Decreases in certain types of violence, which can lead to death, potentially increases in due to other causes, due to people, not seeking care for infections and so forth. Also interested in identifying more sources of mortality data. One of the things that we're doing with the Washington Post is we're able to get access to a large obituary database, which basically captures all of the newspaper obituaries in the country. I'm trying to figure out how to pair this with the official statistics to get sort of more timely estimates of the death rates in different states. So the preprint for this is online. It's a bit out of date already. That's kind of the problem with working with data that are updated each week, is that as soon as posted, it's out of date like 3 days later. But the preprint is up describing the methodology, and then we're hoping to continue updating this and hopefully get it submitted to an academic journal very soon. So I'd be happy to take any questions if there are any, and thanks again for having me.
So any questions for Dan?
Hi, Dan. This is really interesting and kind of unsettling for those of us who are trying to rely more on the data than just modeling it, I guess. One thing I think is that COVID deaths tend to be much more florid than regular influenza deaths, and I think they're generally more recognizable. Whether that matters for collecting their numbers, I don't know, but at least I think there's a little more reliability in coding of death certificates when COVID-19 is involved. I noticed that you didn't include Connecticut data in any of that. I would have liked to see what Connecticut is doing with respect to, kind of the same behaviors. It's probably the same. It seems to me that within states, you'd have better reporting than in a national database because there's one extra step of getting from the state to the national database. So it might save a little bit of time in that respect. And the other thing is, you mentioned a delay. So there's also the same kind of reporting delays in incidence data, count data, not just mortality data. And there's a very interesting pattern. If you, I spend most of my web effort in the website Worldometers for coronavirus, which is virtually up to the minute. Every time they get a new report, it's posted into the counts in that site. So it's very complete and accurate. And they show by the data by countries and historical data up to the present. And if you look at the data in Israel, you'll see that there's actually been two epidemics. That it went up and they put the country on lockdown and it went back down, but not everybody complied. There was a whole subsegment of the population that didn't comply, that didn't mix with the rest of the population. And so they got the infection a week later. And so they had a second epidemic that went up, and then they finally started to comply with it, and that came down. So you see this bimodal pattern in the incidence, and you see a bimodal pattern in the mortality shifted by 5 days later. Exactly the same that you were saying, that the mortality tends to track with the incidence with a delay of about 5 days. So it's seen very clearly in the difference between the bimodal peaks in those data.
Yeah, thanks. Yeah, so in terms of why we don't have Connecticut, so Connecticut actually hasn't reported data, or it's not in the NCHS database since January. I don't know why. But yeah, I think them and North Carolina are the only two states that are not in the national database for some reason.
The Connecticut data are online on the state website for coronavirus, and there's in the transparent data section of the Connecticut state website, there is a zip file for every day from, I think, March 31st or March 21st through the present. And it's updated every day around 4 o'clock.
Do they have total number of deaths, or is that coronavirus deaths?
It's all coronavirus related.
Yeah, so our challenge has been in getting sort of the total death numbers. Like New York City also doesn't release, like they release them to NCHS, but they don't sort of themselves release the most up-to-date numbers on total deaths and pneumonia deaths and so forth. Yeah, certainly the state level, the state data are typically more complete and up-to-date than the federal data. Federal data that we use are released every Friday, so many of the states are updating them more commonly than that, or more frequently than that. But obviously, it takes a lot more work to go to 50 states as opposed to sort of one location. From what I've seen, the state data aren't necessarily more complete; they are more timely. But if you compare, on a Friday when the data get released by NCHS to what's on the state's websites on the same day, they line up pretty well. So there's not a huge sort of delay in sort of reporting them to NCHS for most of the states. It's not universally true. In terms of the Israel situation, that's interesting. I mean, I think in a lot of places, looking at the aggregate data, also there are often sort of smaller epidemics that when you sort of look in aggregate, they looks like multiple epidemics, which it is, but geographically, in the U.S., there's certainly variation as well in terms of when the epidemics are peaking. And I suspect, as New York is going down, it might, in the aggregate data, it might look like there are sort of a second peak due to other parts of the country coming up.
So the big problem really is that if the numbers don't stabilize for 3 or 4 or longer weeks, we have no idea whether the epidemic is going down or not. And how can we make policy recommendations on that basis?
Yeah, so death data in general isn't great it's a lagging indicator of epidemic intensity. So it's not a great thing to track if you're sort of interested in looking at the progression of the epidemic. You really want to look at some of those syndromic indicators. like emergency room visits, which have their own biases and issues, but that's sort of what's currently recommended at the federal level is that the states look at the syndromic data to sort of look at trends in COVID-like illness for people going to the ED.
And within Connecticut, I don't know that those data are available.
They are available. They're not publicly available, but I've done some work with the state DPH to look at them.
In real time, you have those data?
Yeah. I don't have the most recent numbers, but the state gets them about 2 hours after they happen. So.
Okay, we could talk offline.
Yeah.
Okay.
Sorry, continue.
I was just going to respond. There's a question in the chat window from Joe Sint about the difference between historical and current year underestimates the ED use due to non-COVID-19 patients not seeking care, and how well the model handles this underestimation. Yeah, so that's sort of about the syndromic analyses, and yeah, that's certainly been an issue. And we've sort of gone back and forth about how to deal with that. So typically, when you analyze these types of ER data or ED data, you use you look at the number of flu-like illness as the numerator, and then your offset term is all visits to the ED. But because of the issue that you raise, that is going to be highly biased because the number of all-cause visits is going down so much and can make it look like the ILI is increasing more than it is. So I mean, basically, we've sort of played around with doing the analyses with or without the denominator and trying to analyze it both ways, but it's a difficult thing to deal with that we don't have a good solution to yet. Other questions?
So I have a very minor question. So I wonder if our ability to, suppose we can offer nationwide testing, COVID-19 testing. So will the underestimate of this potential underestimate of the total death number due to COVID-19 be more accurate, or it's not the case? It's still have excessive underestimate?
It might. I suspect it'll still be an underestimate. I mean, Harvey noted, that maybe it's easier to make the call here, but I think there is still a number of quite a large fraction of the deaths where it's sort of a gray area. It's just sort of the contribution of COVID, and so I suspect testing will help. And we've seen in New York that as testing ramped up, the gap closed a little bit, but there's still sort of a pretty large fraction that were not being sort of diagnosed as COVID. The other sort of caveat to all this is, it's impossible for us to fully say that any increase that we see are actually coronavirus deaths. They could be deaths due to other causes related to the lockdown, and I think that's important to keep in mind. Although, where we're seeing the strong increases in deaths are the places where the epidemic has been most intense, and we're not seeing strong increases in all-cause deaths in places that have had less severe epidemics, which suggests that at least a pretty good chunk of it is actually due to the virus.
Thanks. Any more questions?
Yeah, I have a question. Last week, the NCHS had a webinar for clinicians on how to sign death certificates, and one of the things they mentioned is they get pretty good subpopulation estimates for every population except for American Indians, which I know some of them live in cities and some of them live in undesignated reservations. Dan, I was wondering if you had encountered anything that would be useful for unpacking that while building this model, especially when you think about reservations like Navajo Nation. And I know they're in states, but they're also kind of outside states. So I was wondering if you could see, I know you're working on an aggregate level, but I was wondering while looking through if you saw anything there that might be useful to inform further.
I haven't seen that. I don't have a sufficient resolution of the data that I have. We're collaborating with Sarah Chronister, who's a YSPH alum who's involved with the coronavirus response for Arizona DPH, and should be good. I'll check with her to see if she has an answer to that. I can get back to you, but it's an interesting question.
Okay, excellent.
Any more questions? So I guess if you have more questions, you can send an email offline. Thank you, Dan, for this excellent talk. And I guess I'll see you guys next week for next seminar.
Okay, thanks a lot.
Bye.